Today we are going to talk about circulation and perfusion. So here as a starting point today, I just kind of want you to remember all the way back to your anatomy and physiology, the pulmonary, the cardiovascular, the musculoskeletal, the neurological systems, all of those systems work together to achieve oxygenation. So I want you to kind of change that thinking of like, okay, we're thinking respiratory for oxygenation because the cardiac system for your circulation and perfusion have a lot to do with oxygenation as well. So all of those systems work together to make sure that our patient and ourselves are well oxygenated. So just keep in mind as you're thinking, changes in one of those systems is going to create changes in the other. They affect each other. They are a balancing act constantly, okay? So our lungs, they're going to oxygenate the blood, right? The heart is going to circulate that blood throughout the body and then back to the lungs to get reoxygenated, okay? The circulatory system is what's going to transport that oxygenated blood throughout the body so that it can meet its needs, oxygenate those tissues, keep us all alive, nice and pink in color, all of that. So when we're talking about the word circulation, that is going to refer strictly to the flow of blood throughout the heart and through the blood vessels. Whereas perfusion, we're going to be thinking about blood flow to a capillary bed that is going to provide nutrients and oxygen to the tissues and organs. So that's kind of where that exchange of nutrients and oxygen comes in, is that perfusion piece. So those two words, very similar, used together often, but that's kind of the difference between the two. So a little refresher on the anatomy of the heart. What are we talking about? So the heart, remember, is a 4-chambered muscular organ. So it is a muscle and it's encased in the pericardium. So that is a sac of connective tissue essentially. And then that heart is located inside that chest cavity. The atria. So the atria, we have 2 atria. They're thin-walled. So their walls are very thin. They receive blood into the heart. That is their job. So the 2 atria right there receiving the blood into the heart. The ventricles, you have 2 of these as well. They are towards the bottom of the heart. So these are 2 thick-walled ventricles. So they're very thick, and they're thick because they are muscular, and their job is to pump blood out of the heart into the rest of the body. Okay? There are valves between those heart chambers, so those valves are going to open widely between the atria and the ventricle, and then from those ventricles to the rest of the body or to the lungs to get oxygenated. So you have valves in there. Their job, they're going to open widely. They're going to allow blood to flow easily without any turbulence or disruption from one chamber to another. And then after they open, they're also going to close tightly to prevent the backflow of that blood. You'll realize as you get deeper into the program, when we start to talk about certain disorders, that backflow of blood can really be detrimental in the oxygenation and perfusion process. So those valves help with that. The base of the heart is also the broadest side of the heart, and that is going to house that atria and face upward. That is your base of your heart. The apex of the heart is also known as the tip of the heart. So that's going to house those ventricles, and it faces downward. So I'll show you a picture here in just a minute. But remember, when we talk about the different words that you can use for like an apical heart rate, the mitral heart rate, the point of maximum impulse, all of those things mean the same thing. And that is just right there at that apex of the heart. So that downward piece that kind of shoots off a little bit to the left, if I'm thinking about myself and the orientation of myself, so to our own left-hand side. So just keep in mind, a strong, efficient heartbeat is what's going to keep that blood flowing throughout that vascular system, okay? Deoxygenated blood from the organs and tissues is going to flow through the venous system, so through the veins. And then remember, that is blood that's already, the nutrients and the oxygen has already been delivered to the tissues and wherever it needs to go. And now that blood is just deoxygenated, needs to be replenished so that we can continue that cycle again. So again, that deoxygenated blood is going to come from the organs and the tissues where it's already left its nutrients, and then it's going to flow through the venous system. Remember, the veins carry that deoxygenated blood, and it's going to go through that venous system up into the right side of the heart and then into that pulmonary circulation where it's going to get reoxygenated before it flows back into the heart and then out to the body. External gas exchange is going to occur at an alveolar capillary membrane. So remember, we talked about our alveoli in our lungs. That's where that external gas exchange is going to happen. And then you have your newly oxygenated blood. That's where it's going to flow from that alveolar capillary membrane there in the lungs. It's going to flow from there after it's been gotten all the nutrients that it needs now. Now your blood is going to flow back into the heart where it is fully oxygenated, back into the heart, the left side of the heart, and then it's going to go out into the arterial circulation. Remember our arteries, that is our fully oxygenated blood that's carrying our blood away from the heart back to our tissues where it can drop its nutrients again to reoxygenate all of the tissues surrounding that need that. And so here is that picture I was telling you about. I highly suggest that if you do not know the way that the blood flows through the heart, that is an extremely basic skill here in nursing school, and that every single other thing that you learn about the heart will not make as much sense, and you will not grasp it as well if you don't understand this picture. So specifically, you definitely need to know everything that I kind of just told you about that pathway through the heart. I'm going to show you a video here in just a second that I feel like really breaks it down so that you can understand it. But this piece, you need to know this. If you view the actual PowerPoint on here, you'll be able to click to watch this video. It won't play in this recording. We are going to go over now the structures of that cardiovascular system. So we're going to start with the heart. So when we're talking about the heart and all that it does, the first step is going to be to get it to beat, right? So when we talk about the cardiac cycle is the sequence of mechanical events that are going to occur during a single heartbeat. So think of it as the movement, the actual mechanical events that's going to be that cardiac cycle. The electrical activity of that myocardium or that heart muscle is going to regulate that cardiac cycle. So there's kind of two pieces to that. All of it is stimulated and initiated by the electrical conduction of the heart. So the electrical activity that's going to start that cardiac cycle. That cardiac cycle is going to stimulate that contraction of those two atria, and then followed right afterwards by the simultaneous contraction of the ventricles. So atria, lub, ventricles, dub, all initiated by the electrical conduction of the heart. So let's dig in a little deeper to that cardiac cycle. So the heart contains specialized areas of nerve tissue that are going to initiate that electrical impulse without external nervous system stimulation. Okay, it just does it automatically. Okay. So we're going to talk about the sinoatrial node or the SA node. This is known as the pacemaker of the heart. It is located in the right atrium, and its big job is to initiate that impulse that's going to trigger each heartbeat. Okay. That impulse is going to travel rapidly down the atrial conduction system so that both sides, so both atria, the one on each side, are going to contract as a unit. Okay. But it's all going to start right there in that SA node, the pacemaker of the heart. After that, then we've got the AV node or the atrioventricular node. That is after the SA node. There is a slight delay there, okay? At the AV node, there's a slight delay. So from the AV node, then the impulses are going to pass into the left and right bundles of His is what they're called. And then lastly, into the Purkinje fibers, which are located in the ventricles. In this way, those myocardial fibers are electrically stimulated almost simultaneously to create kind of a unified cardiac muscle contraction that's going to be strong enough to pump that blood out of that heart chamber, right out of those ventricles and into the rest of the body. This spontaneous rhythm of the heart is going to be called automaticity, okay? If there are any defects in that electrical system, those impulses are going to travel more slowly through the heart at that point, and some of those areas may contract before others. This can cause ineffective heart pumping and decreased cardiac output. Okay, so when we talk about ineffective heart pumping, we're talking not all the blood that's supposed to be coming out is going to be coming out, because it's not going to be firing, and that muscle strength is not going to be there in order to forcefully push that blood out where it needs to go. In the same way you may be familiar with in heart failure patients that you may have seen on your units where you work, but and then causing that decreased cardiac output. So the amount of blood that is coming out of that ventricle into the rest of the body is going to be decreased. So here's just a visual for you. This is right out of your book, and you can see up there to the left the SA node, and you can see that's right there in that right atrium. You can see where the bundle of His is located, the AV node, and then your bundle branches. You don't really need to get too big into knowing all of that or the conduction of the heart right at this moment. You will dig into that into your med-surg class, where they will teach you how to read EKG rhythm strips and things like that. But for now, you just need to know, first of all, that SA node, pacemaker of the heart. That electrical impulse is going to start there, and it's going to go down to that AV node, then to the bundle of His, then down to your Purkinje fibers there in the ventricles. You can see kind of below that picture of the heart, you can see a normal sinus rhythm strip kind of down there, what you can see with the beat of the heart. So you've got your P wave, you've got your QRS, and then your T wave here off to the end. And that's kind of what you're looking for. We're not going to get too big into what all of that means until later. Now we are going to talk about some systemic and pulmonary blood vessels here. So when we talk about the vascular system, keep in mind it's composed of 3 types of vessels. So we have arteries, we have veins, and we have capillaries. All vessels are lined with a smooth endothelial layer that promotes non-turbulent blood flow, so very smooth blood flow, and attempts to prevent platelets from sticking to the sides of that wall of the artery or vein or capillary, and prevents it from beginning to clot. So when we're talking about arteries have thick elastic walls that allow them to stretch during a cardiac contraction or systole, right? So when we're talking about blood pressure, we're talking about our systolic and then our diastolic, right? Top number, bottom number. Systolic or systole is when your heart is actually contracting, when it is working, right? So those arteries, they stretch during that systole or during that contraction, and then those elastic walls also allow a recoil when the heart relaxes in diastole, right? Or that bottom number of that blood pressure, the resting piece of the heart before it gets ready to pump again. Then we have arterioles. So those are smaller branches of arteries. They are primarily smooth muscle, and they're a little thinner than arteries are. These arterioles are going to be under the control of that sympathetic nervous system. So those arterioles are going to constrict or dilate to vary the amount of blood flowing into the capillaries and help maintain that blood pressure. So again, remember that sympathetic nervous system, that's your fight or flight. So that's going to greatly control these arterioles here. And then we are going to talk about capillaries. So these capillaries, these are going to be microscopic vessels, right? Very, very, very teeny tiny, small. They are created as those arterioles branch into smaller and smaller vessels, okay? They are only 1 cell thick. So capillaries, only 1 cell thick. And their big job is to facilitate the exchange of gases, so carbon dioxide, oxygen, nutrients, and waste products, carbon dioxide, between the tissue cells and the blood, okay? And lastly, we're going to talk about veins and venules. So both of those, very thin but muscular, but also inelastic. So when we talked about our arteries, those were elastic. They can stretch and recoil. Veins are not that way. They are inelastic in their walls, and they collapse very easily, okay? Those walls are going to contract or relax in response to feedback from that sympathetic nervous system once again, okay? So think about it like this. When blood volume is low, so maybe you have somebody who's hemorrhaging or they have a gunshot wound or something, those veins are going to contract or squeeze together, get smaller to provide a smaller space for that smaller volume of blood, okay? And that is what's the body's compensatory mechanism to kind of try to increase that blood volume, right? When the blood volume is high, so maybe you have somebody who has that, who's just got fluid volume overload or something like that, congestive heart failure, you'll see that. When that blood volume or fluid volume is high, those veins are going to relax now, which is going to enlarge that inner space to accommodate an increased volume of blood. Think of that venous system as kind of like a holding tank for any type of fluctuation in blood volume. It's going to kind of counteract that, be that balancing system to kind of prevent any complications from being either too high on that fluid scale or too low on that fluid scale. Moving on to the coronary arteries. So keep in mind, every single organ, every single tissue in your body needs a blood supply with all that oxygen, nutrients. It needs to be supplied by that in order to function correctly. So the coronary arteries is going to be the heart's very own blood supply. And that is what's kind of giving the heart that nutrients, the ability to pump and things like that, right? So the coronary sinus, which is located just above that aortic valve, is going to fill with blood during that diastole or that resting phase of the heart. From the coronary sinus, that blood is going to flow into the two main coronary arteries, which are going to branch into several sections to supply the heart muscle with blood, okay? The coronary arteries are actually the only arteries in the entire body that actually fill during diastole or during the rest period of the heart. Here's just a knowledge check just for yourself. I would suggest that in these knowledge checks, and these go straight along from your book, and these are basically just little checkpoints here that say, do you know what this is? If you don't know how to do these things by the time you get to this portion in your book, then you have not understood the material before that. So you, at this point, should be able to describe the difference between oxygenation and perfusion. You should be able to trace the path of normal electrical impulses in the heart. You should be able to know how the walls of the arteries, veins, and the capillaries are different. And you should also know what the importance of diastole is in perfusion to the heart. At this point, we know that our cardiovascular system is comprised of the heart, the blood vessels, and the red blood cells, which flow throughout the blood vessels, correct? So now we're going to talk a little bit about hemoglobin, which is also kind of in there with these red blood cells, these blood vessels, and its main function is to carry oxygen. Okay, you need to know that. So 97% of blood oxygen is bound to the hemoglobin molecule. Okay, hemoglobin is an iron-containing protein that is inside these red blood cells, right? So only 3% of that oxygen is actually in a dissolved state and able to be used, right? So the rest of it's just kind of hanging out, 97% of it hanging out in that hemoglobin, kind of like a buffer or a reservoir, right? Just in case the patient may need it, we need it, right? So oxygen will actually leave that hemoglobin, then become dissolved into the blood and pass through that capillary membrane into the tissues to oxygenate those tissues. Okay, only the dissolved form of oxygen, or O2, can pass through the capillary membranes. So hemoglobin, like I said, is going to serve as a reservoir for oxygen until it's needed in that dissolved state. So it doesn't matter how much oxygen you have stored on that hemoglobin. If you only have a certain amount in that dissolved state, that is all that is getting into those capillary membranes. So that hemoglobin is a reservoir for that. Okay. Carbon dioxide. So we know carbon dioxide is a waste product of normal aerobic tissue metabolism. We all have this. It is a byproduct. CO2 is going to diffuse through that cellular and alveolar capillary membrane. But again, only in its dissolved state. Carbon dioxide can be carried in the blood in 3 ways. So it can be dissolved in plasma. 23% of it actually attaches to the hemoglobin. The CO2 that's bound to that hemoglobin eventually detaches and becomes dissolved in the plasma for diffusion into the alveoli of the lungs. Okay, and then 70% of that is actually converted into bicarbonate ions. The bicarbonate ions in the plasma are then converted back to CO2, which becomes then dissolved, then diffuses into the alveoli like we just talked about, and then eventually is exhaled by the body. Okay. Again, we'll come to this point again. We've got arteries, we've got veins. Remember, arteries carrying oxygenated blood to the tissues, veins carrying deoxygenated blood back to the heart or the lungs. And a clicker check. The atrioventricular or AV node is the pacemaker of the heart. True or false? That is false. So just remember, located in the right atrium, that SA node is acting as the pacemaker of the heart. So the sinoatrial node in the atria acting as the pacemaker. That's what's going to initiate that impulse. It's going to stimulate that heartbeat, and then it travels down, like we talked about, to the AV node, then the bundle of His, the Purkinje fibers, all of that stuff. Now let's talk a little bit. We know the structures of the cardiovascular system now. So now let's talk about how the cardiovascular function is regulated. What is our body doing to get our heart to beat all the time, to get it to increase when we need it to get it to decrease when we need it to? Remember, the autonomic nervous system contains sympathetic and parasympathetic fibers. Okay, taking you back to kind of anatomy and physiology, a little refresh here. Just remember, the autonomic nervous system regulates cardiovascular function. Okay, remember, back to anatomy and physiology, the autonomic nervous system is a component of that peripheral nervous system that regulates involuntary physiological processes, including heart rate, blood pressure, respiration, digestion, sexual arousal, all of that. The autonomic nervous system has a hand in that. The heart has both sympathetic and parasympathetic fibers. Sympathetic control is going to maintain the blood vessels in a constant baseline state of partial contraction or tone, right? It's going to be partially contracted. That vascular tone is what keeps our blood pressure and blood flow even while we're resting, while we're asleep, and prevents us from going super hypotensive or not getting enough perfusion when we're really not walking around and doing a whole lot, right? So remember, that sympathetic control is what's controlling that. That's involuntary, just totally controlling that for us. Sympathetic stimulation varies in response to the body's needs. Okay, so increased sympathetic stimulation is going to cause a couple of things. So first of all, it's going to cause constriction of some blood vessels. So for instance, skin, the GI tract, the kidneys. Secondly, it will cause dilation of other vessels, so like skeletal muscles. This shunt of blood flow to the skeletal muscles, and it's going to stimulate the heart to beat faster and to contract strongly, right? Think fight or flight. So when we talk about constricting some vessels, for instance, like we said, to the skin, to the GI tract, we don't need to pee or poop when we are running from a lion, and our body knows that. So it's going to shunt the blood away from that, and it's going to give our skeletal muscles the blood flow and the energy and nutrients that it needs so that we can fight and get away from this. It's going to kind of shut down, not totally shut down, but like at least slow down some of those processes that we don't need in this extremely intense moment. And it's going to shunt that blood to where we actually need it so that we can get away from whatever is deemed as a threat, right? So your fight or flight response, your sympathetic fibers. All right, and then our parasympathetic fibers. Those are going to balance that response through the vagus nerve. Okay, we talked about the vagus nerve. We talked about our cranial nerves. What that's going to do is it's going to slow down our heart rate, but it actually doesn't have much influence on muscle contractility. However, when that vagus nerve is stimulated, such as straining during a bowel movement, pushing against a closed glottis, so if you close your mouth and kind of plug your nose and push, that is also stimulating that vagus nerve. So when it's stimulated, there is a sudden drop in the heart rate, okay, and the blood pressure. And these things can cause dysrhythmias, they can cause lightheadedness, they can cause nausea, sweating, even syncope or fainting. This is similar to the type of response you may see when if somebody gets queasy at the sight of blood and then they pass out on the ground. Pushing during a bowel movement, if anybody's ever heard the term the patient vagaled out, you see this a lot in elderly patients. It's actually how Elvis died. So vagal nerve stimulation, that is what it's doing, and that is like a parasympathetic response. All blood vessels have sympathetic fibers and have little effect from parasympathetic fibers. So sympathetic control is going to maintain that blood vessel in that constant contraction or constant tone, no matter what. And then obviously, like we talked about with our sympathetic response, it's going to increase. With our parasympathetic response, it's going to decrease or balance that out, so to speak. Brainstem centers. This is also going to help regulate cardiac function and blood pressure. So brainstem centers are going to integrate feedback from those baroreceptors and chemoreceptors in the body to regulate the cardiac function and blood pressure. Okay, so the vasomotor center controls sympathetic stimulation of the heart and vascular system, and the cardioinhibitory center controls parasympathetic slowing of the heart rate. Okay. When we talk about baroreceptors and chemoreceptors, when we're talking about baroreceptors, those are located in the walls of the heart and blood vessels, sensitive to pressure changes. Okay, the aortic arch and the carotid artery baroreceptors are particularly important in the regulation of heart rate and vascular tone. When baroreceptors sense even a small drop in pressure, they send messages to the brainstem centers to stimulate the sympathetic nervous system to increase the heart rate and induce vasoconstriction, right? Which means the vessels get smaller. Okay? This mechanism allows us to change positions and still maintain our blood pressure. Okay? When we're talking about the vascular system, chemoreceptors are located in the aortic arch and the carotid arteries as well, and they're sensitive to changes in blood pH, oxygen levels, CO2 levels. Their main function is to regulate ventilation, but they also send information to the vasomotor system in response to like a lack of oxygen. So the vasomotor center responds by activating that sympathetic stimulation. There are many things that can influence cardiac function. So first of all, our developmental stage, okay? At every stage of life, we have different cardiovascular needs, some more than others. Some stages of life, our cardiovascular function starts to decrease, and some it starts to increase, such as when you're an infant, right? So when we're talking about developmental stage for an infant, successful transition from life inside the uterus to that extrauterine environment is going to depend on some critical physiological changes that are going to occur at birth. So keep in mind, we know that prior to delivery, the fetus uses the placenta for gas and nutrients exchange. It completely bypasses the lungs. Fetal circulation completely bypasses the lungs. It shunts the blood elsewhere. However, when the infant is born and that umbilical cord is clamped and then that newborn takes that first breath, the resistance in that pulmonary vessel then decreases significantly. The lungs at that point are forced to inflate and the blood circulates without shunting just like it did in fetal life. Then it closes all of those shunts. In a perfect world, we'll find out later in this program how sometimes those can remain open and cause cardiovascular issues and things like that. However, that's the idea, that those shunts will close with that first breath, and then their circulation changes completely from how it bypassed the lungs and all of those things, and it changes to a normal pathway of blood through the heart, just like we just learned, that of an adult. When we talk about preschool and school age kids, so these kiddos have body systems mature enough to adapt to moderate stress and change, including the heart and circulatory systems. However, children as young as school age sometimes begin social habits such as tobacco use. That can have long-term adverse effects on the cardiovascular system, as we know. Also, a diet high in fats and sugars is going to contribute to hyperlipidemia, or high fat in the blood. And then the beginning of that plaque lining to start to accumulate in the vessel walls, leading to atherosclerosis, and then increasing the risk for an eventual heart attack or stroke or whatever it is. And again, we're just talking about preschool and school age. This all has to do with our food. Okay, processed food contains a great deal of salt and fat, which can contribute to not only these changes in the blood vessels, but also an increased blood pressure, high cholesterol, even in children. I do believe now it is standard that they are checking cholesterol on children, I believe at like 8 to 10 years old these days. Adolescence. So when we're talking about this age group, developmentally, they're at little risk for heart or circulatory disorders, although some athletes can be at risk for collapse and sudden cardiac dysrhythmias, especially if they have a certain family traits and genes and things like that. Some adolescents adopt behaviors and habits that can create risk throughout life. As we know, 87% of adults who use tobacco were regular smokers by their 18th birthday. And almost 25% of high school students reported using 2 or more tobacco products during the last 30 days. So that's something as well that we need to consider. And we're not just talking about tobacco even these days. We're also talking about nicotine. We're talking about vapes, all the things, okay? Also, the incidence of childhood obesity is also rising, and it is an epidemic here in the United States. So that also can affect cardiac function as well. Young and middle adults. So with them, some risks that we're kind of looking at as far as influencing cardiac function, we're talking about possibly a sedentary lifestyle, a lack of aerobic exercise, tobacco use as well. All of those things can contribute to cardiovascular disorders. Crack cocaine and methamphetamine abuse can lead to sudden cardiac failure. Family history of cardiovascular disease is yet another risk for this age group. And then older adults, as we age, that cardiac efficiency gradually is going to decline as that muscle loses the strength. Heart valves become thicker and more rigid while the vessels become less elastic. This age group of adults have a lower exercise tolerance, so they can't do the same amount of activity that do younger, more spry individuals. They need more rest after exercise, and they are more prone to orthostatic hypotension, which, if you remember back to your vital signs lecture, is when your blood pressure drops when you have a position change. Other things that are going to influence cardiac function, our environment is also a big thing. So stress, that stress response stimulates the release of catecholamines from the sympathetic nervous system. This is going to result in an increased heart rate and contractility. It's going to cause vasoconstriction, right, where those vessel walls constrict or get smaller. It's going to also increase the tendency of blood to clot as well. A stress response will do that. Sustained stimulation of that sympathetic nervous system can lead to cardiovascular disease. In addition, a chronically suppressed immune and inflammatory response is going to increase the risk for all infections as well. Couple other things. So allergic reactions and air quality. So an allergy is going to be a hypersensitivity or an over response to an antigen of some kind. Inflammatory substances are going to be released during an allergic response, so such as histamine, if you've heard of that. That's going to cause the following effects on the cardiovascular system. So once you get that allergic response, you've got that histamine secreting, blood vessels are going to dilate in the areas that are affected, right? Which is going to increase the blood flow to those areas. So that's when you start to see the redness start to appear. That just tells you that those blood vessels are dilating under the skin when you can start to see that redness. Eosinophils and neutrophils are attracted to that reaction site. And then local tissues are going to be damaged by protease, okay? Capillaries are going to become more permeable, which permeable just means that fluid and different molecules and things can go in and out of that vessel, that capillary. That's going to result in fluid leaking into the tissue, so swelling or edema, right? And then that local smooth muscle cells are going to contract, so otherwise known as your vascular areas are going to contract. Altitude plays a big role as well. So when we're talking about oxygen pressure, when that falls proportionately with increased altitude, it makes oxygen available in the it makes more oxygen available in the alveoli and at the tissue level. So over the long term, people who live at high altitudes undergo actual physiological changes that facilitate oxygenation. So what it's going to do, it's going to increase production of the red blood cells. It's going to increase the vascularity of those body tissues. It's going to increase the ability of those tissue cells to use oxygen, even when the atmosphere oxygen pressure is low. Okay. And then heat and cold. So heat is generally going to cause vasodilation. Okay, so those blood vessels get bigger, they dilate. That's what's going to increase cardiac output, and it's going to increase oxygenation as well. However, heat is also going to increase metabolism. So as a result, people who are naturally more sedentary, or people are naturally more sedentary in like hot weather, right? When we talk about applying coldness is going to slow that cell metabolism. It's going to reduce that oxygen demand. It also causes vasoconstriction, so that's going to make those vessels smaller. That's why we use cold packs for swelling, right? It's going to cause that vasoconstriction. It's also going to slow the heart rate. Okay, induced hypothermia is used in some surgical procedures. As another example, victims of cold water near drowning have actually been revived after long periods of time, in part because the reduced oxygen demands associated with that are associated with hypothermia. If you've ever heard of like people saying that people have been frozen or things like that, I actually saw a story once where a man had hitched a ride on accidentally. I think he was trying to flee from another country or something, but he had like hitched a ride on the belly of a plane or something ridiculous. Like he went to another country on the outside of a plane, and when the plane landed, like he was dead essentially, but frozen. He was so cold, and he eventually came back to life because of the decreased O2 demands because of his frozen body. He actually lived. They got him back several hours later. Lifestyle stuff that's going to affect that cardiovascular function. So pregnancy. When we have a pregnancy, oxygen demands are going to increase dramatically. To compensate, the mother's blood volume has to increase as well, which typically happens around 30%. The blood volume increases during pregnancy. Additional iron is also required to produce this blood as well as to meet fetal requirements. Maternal metabolism increases by approximately 15% during that last half of pregnancy. Nutrition is going to be another thing. So a diet that is high in saturated fat is going to predispose someone to the development of that atherosclerosis, coronary artery disease, hypertension, all of that stuff. All of those can compromise circulation and oxygenation. And on the flip side, a low-fat, low-cholesterol, low-sodium diet is technically considered heart healthy. Right? Vitamins, minerals, especially iron and protein, are super important to prevent anemia, which anemia reduces the blood oxygen carrying capacity. So we want to prevent that the most we can. So increasing iron would be a way to do that. Obesity. So BMI above 30 is what we're talking about with obesity. It is going to cause multiple heart problems, which can all affect the heart and circulation. Increases the risk for developing the atherosclerosis and hypertension or high blood pressure. Excess fat stores in and around the heart itself, reducing its effectiveness to pump. If we have a weak pump, we are going to notice perfusion problems, edema, decreased perfusion, all of that. And then the workload of the heart is going to be significantly increased by the need to perfuse that excess body fat. Exercise. So exercise improves blood circulation and delivery of oxygen to tissues and cells. It's going to increase the metabolic demand as well. The body is going to respond by increasing the heart rate and increasing the rate and depth of breathing. Just like skeletal muscles, the heart muscle is strengthened with regular aerobic exercise. So we know exercise is good for us. Tobacco use. This is a major risk factor in several chronic cardiovascular conditions like stroke, peripheral artery disease, aortic aneurysm, heart disease, all the things, right? Also is implicated in atherosclerosis. So remember, that's that fatty buildup in the arteries that's going to cause the narrowing of those vessels, leading to possible MI or a heart attack or a stroke. Can also be implicated, tobacco can also be implicated in hypertension and decreased HDL cholesterol, which is your good cholesterol, which we want to be high or at least normal, right? Because it's your good cholesterol. All of those things together can lead to coronary heart disease and or a heart attack. Substance abuse. So large amounts of alcohol is going to depress that respiratory, cardiac, and vasomotor centers in the brain. Chronic alcohol abuse causes fatty infiltration of the heart muscle, thrombi or clots in the coronary arteries, heart enlargement or cardiomegaly, and dysrhythmias, which is abnormal beating of the heart, right? All of those things can ultimately lead to heart failure. And then, of course, illicit drug use, including stimulants such as methamphetamine or cocaine, hallucinogens like LSD, cannabis even is on here to have adverse effects to the cardiovascular system. And medications can also affect that cardiac function. Here's some of the most common medications that are going to affect that cardiac function, which you'll dive deeper into once you get into those later classes in the program. So NSAIDs, an example would be aspirin or ibuprofen. Aspirin specifically is going to block that production of prostaglandin in your body. Prostaglandins actually activate the formation of blood clots. It signals that there's injury somewhere in the body. And then it also causes pain. That is part of that. So when this is in the blood, it actually thins the blood and decreases the pain. Aspirin, thins the blood and decreases the pain because it's going to block the effect of that prostaglandin. This is going to reduce the risk of heart attack or stroke. It's going to decrease inflammation. That's why if you've ever heard of somebody thinks that they're having a heart attack, they actually recommend that they chew an aspirin. Chewing it gets it kind of into the body a little bit quicker and will help kind of thin that blood while the patient is en route to the hospital after that event. So one big thing with NSAIDs, whether it be aspirin, ibuprofen, any other type of NSAID, remember, because it's thinning the blood, it also that known effect of it can also turn into an unwanted effect and cause increased bleeding. We always want to take NSAIDs with food. Okay, they can be very irritating to the stomach lining. They can cause a GI bleed if you've ever heard of that, and it can cause gastritis and all of the things. So we want to make sure that we instruct our patient to give this medication, to take this medication with food, but we also want to be aware of that as nurses as we're giving these kinds of medications, that we don't want to give this on an empty stomach. Vasodilators, some examples of that would be lisinopril, nitroglycerin as well. What these are going to do, they're going to enhance cardiac output, which is going to increase that blood flow to the heart, cause that vessel dilation, which is going to then ease the workload of the heart, right? It's going to control the blood pressure, and it also is used to treat heart failure as well. Specifically with nitroglycerin, otherwise known as nitro for short, it can have a significant effect on blood pressure. That is extremely important to know. So anytime you are giving nitro, typically we're giving this for chest pain. Patients will have it ordered for chest pain. Before we give it, every single time before each dose that we give it, we want to check the blood pressure because this can significantly drop the blood pressure. Okay, so we're going to check that blood pressure before each dose. With nitro, you can repeat it every 5 minutes for a total of 3 times. We're not going to give it no more than 3 times. If we give it 3 times and the patient's chest pain is still not gone, we are either sending them to the ER or following up with the doctor about that as well, because it could be something more serious than just angina or chest pain, otherwise known as chest pain. Also, one really big thing with nitro, we don't want to touch it without having gloves on. This comes in a variety of different routes. You can get it as a patch. You can also get it, in these little tablets. You can get it as a paste as well. This absorbs through the skin rather quickly, which is how it's given via paste, right? And so we always want to wear our appropriate PPE, so gloves in this case, because it can absorb through our skin and have a significant effect on our own blood pressure as we are handling this. So that's very important. Beta adrenergic blocking agents. So this is going to be your metoprolol, your carvedilol, propranolol. All of these are going to be used therapeutically to reduce that workload of the heart. And to control any abnormal heart rhythms. Can also be used to control hypertension. Okay. Drugs that block the beta 1 receptors actually slow the heart rate and decrease the strength of myocardial contraction. I always tell students when they are giving a beta blockers are not necessarily specific to the receptors that they are blocking. And so these beta blockers specifically are going to, like it said here, it's going to decrease not only the blood pressure on these patients, but it's also going to decrease that heart rate, which usually when you're giving metoprolol, you'll see that there is a note on the screen that will say, don't give if your patient's heart rate is less than 60. So that is important to know as well. And then lastly, we have calcium channel blocking agents or calcium channel blockers. An example of this would be nifedipine or nifedipine. I've heard that. I've actually heard a little acronym to remember nifedipine is that your nifedipine is going to decline your blood pressure. Actually, what it's doing, it's going to block that flow of calcium into the cells of the heart and the blood vessels. They're going to decrease the blood pressure, and they're also going to decrease the strength of that myocardial contraction, slow the heart rate, dilate those arteries and the arterioles as well. And then cardiovascular abnormalities, of course, are going to affect that cardiac function. So with heart failure, if you've ever seen a patient with heart failure, what actually happens with these patients is that the heart becomes an inefficient pump and is unable to meet the body's demands. Think of it as like a weak muscle that cannot just make that contraction to get that blood out as forcefully to where it needs to go. So it goes slow and it goes weak. So not as much blood is coming out as would be in a normal person, right? The blood is oxygenated when it passes through the lungs, but is not well circulated to the organs and the tissues. So all those organs and tissues are not getting the blood flow, the nutrients, the oxygen that they need because it's such a weak contraction of that heart muscle. That impaired circulation is going to lead to systemic, so all throughout the body, and pulmonary edema, right? So you'll have systemic edema, so feet, legs, also known as peripheral edema, right? And then also pulmonary edema, which is when you have that edema in the lungs and can cause all kinds of horrible symptoms and things like that. So all of those things, that edema, the systemic and pulmonary edema, is all going to impair gas exchange, cause that shortness of breath, respiratory distress if left untreated, right? Cardiomyopathy, this is a heart muscle disorder that results in heart enlargement and impaired cardiac contractility, okay? Cardiac ischemia, just remember, anytime you're talking about ischemia, we mean no blood flow, lack of blood flow. That is what ischemia means. So with this, oxygen requirements of the heart are unmet, right? Because the heart is not getting the blood supply, the oxygen that it needs in order to function. Prolonged ischemia is going to lead to a myocardial infarction, otherwise known as an MI, otherwise known as a heart attack. With that happens because parts of the heart die from inadequate oxygen. That is when your MIs or your heart attacks happen, right, from cardiac ischemia. And then some things that can cause cardiac ischemia: stable and unstable angina, which we talked a little bit about on the last slide, right? So when we're talking about stable angina, remember angina just basically means chest pain, okay? So with stable angina, we're talking about a predictable pattern of ischemic chest pain that is precipitated by some kind of known trigger, maybe people who say they get chest pain every time they work out or every time they eat a large meal or every time they're exposed to extreme temperatures, whether hot or cold, every time that they smoke, every time they have sex, things like that. The big thing you want to remember with stable angina is, first of all, it's predictable. And then it also is relieved by rest and or medications. Okay, so stable angina, those are the big things to remember. When we're talking about unstable angina, this is ischemic chest pain that has worsened in frequency, severity, or duration and is unrelieved with those usual measures. So if somebody has stable angina and they take a couple doses of nitro and that usually helps, but this time it doesn't, now they have unstable angina and they need to go get that checked out, right? Untreated, unstable angina can lead to a heart attack or myocardial infarction, MI, lots of different names for the same thing, but it can lead to that. So that's important to know. Coronary artery disease. So this is a condition in which plaque builds up inside the coronary arteries. Okay, the plaque that's inside those arteries is actually going to narrow those arteries, right? Which is going to reduce the blood flow to the heart muscle and make it more likely that clots will form and block those arteries. Because if you remember, your arteries along those walls have those cells that are going to make it hard for those blood cells to clump together and clot together, right? Well, if those walls of the arteries are blocked by the plaque, then that function is not happening as well, right? So that puts us at a higher risk for clots when that happens. And then dysrhythmia. So this just means some kind of alteration in the heart rate or rhythm, okay? It's going to cause lower cardiac output, and it's also going to decrease tissue oxygenation with these as well. And then heart valve abnormalities also can influence this cardiac function. So when we have an abnormality with the heart valve, it's going to create turbulent blood flow. This is going to lead to a decrease in cardiac output and compromised tissue oxygenation as a result. Okay. Often you can hear an audible heart murmur when you have some kind of valve dysfunction. Valves most commonly affected by this is going to be your mitral and your aortic valves. And then peripheral vascular abnormalities. So when you're thinking and you're hearing the word peripheral, just remember that all that means is that we're talking about an area far away from the heart or distal to the heart, not central, right? Not central right around the heart, but distal or peripheral you could use interchangeably in that way. That being said, we're talking extremities, right? Arms, hands, feet, legs, those kinds of things. So peripheral vascular, so the vascular system in those peripheral areas, so hands, feet, legs, arms, right? So those abnormalities are going to impair blood flow to and from the organs and tissues, right? Arterial abnormalities are going to disrupt the flow of oxygenated blood to the tissue. So I want you to think about that. So arterial abnormalities are going to disrupt the flow of oxygenated blood to the tissues, right? Because arteries are carrying oxygenated blood, right? So when there is some kind of disruption in that flow, what kind of symptoms are we going to see when that oxygenated blood is not getting where it's going? Well, those symptoms are going to be pallor because the red blood is not getting there to color that. It's going to have pale extremities. It's going to be pain because we have ischemia, right? When we don't have the oxygen, the nutrients, all the blood flow going directly where it needs to go, you're going to have pain. So ischemia is going to cause pain, right? Weak or absent pulses because we know that the heart is not pumping as well as it should. So the force is not as high as it usually is. So your pulses are going to be weak or absent, right? Poor capillary refill because we know that that has to do with circulation. And then cool skin, right? Warm skin is going to be your well oxygenated skin down there because remember especially when we're talking about the legs and feet, that is the farthest spot on your body where the blood has to flow, right? It's hard for it's hard in general for the heart to get the blood all the way down there, but especially when you are having cardiovascular dysfunction, that is the hardest place for the blood to get. It's just the farthest place away from that central area where the heart is located. So cool skin, especially down there on the legs, ankles, and feet, okay? And then when we're talking about venous abnormalities, this is going to disrupt blood return to the heart, okay? So we're talking about that deoxygenated blood that's coming back to the heart to try to get reoxygenated. What are we going to see with that? Well, when we have venous insufficiency, we're going to see edema, okay? That fluid is going to pool there in their feet and legs. We're going to see a brownish skin discoloration, and then we're going to see stasis ulcers. So if you're having a pooling of blood, so to speak, you start to get those stasis ulcers. And then lastly, oxygen transport abnormalities. Okay, so remember, even if the heart is functioning well and arterial blood flow is intact, tissues can still become hypoxic if the blood is unable to carry an adequate amount of oxygen. Okay, so such as anemia, right? So anemia is an abnormally low level of red blood cells, hemoglobin, or both. Okay, so you don't have enough cells to carry that oxygen to get those nutrients and all that stuff where it needs to go. So they may not have a problem with the pumping of the heart, but if they don't have enough cells to oxygenate those tissues, that's a problem too, right? And then carbon monoxide would be another oxygen transport abnormality. Carbon monoxide is a colorless, odorless gas that is produced by the combustion of flammable materials and fuels. When it is inhaled, carbon monoxide actually binds really tightly to hemoglobin at those oxygen receptor sites. So if your hemoglobin can only hold 4 oxygen molecules, and carbon monoxide is inhaled, it will actually take up those 4 spots so that the oxygen cannot attach onto that cell, which is going to cause a decrease in oxygen. And that's how it kills people, right? Because it makes it impossible for that hemoglobin to carry that oxygen because it's already occupied by that carbon monoxide molecule. So now we get to our favorite part, which is what are you going to do about it, right? Well, our first step is always to assess our patient. Okay, so just keep in mind as your conditions with your patient get more serious, we're going to let the patient condition guide our assessment, right? So, for example, if the client is having a cardiac emergency, maybe we're going to quickly ask them what happened, what's your current symptoms, while we quickly perform a focused assessment to determine the adequacy of their circulation, perfusion, and their oxygenation, right? We're going to kind of be doing all of those things at the exact same time, right? Really quickly. However, if they're at a doctor's office for an annual checkup and we are assessing the risk for coronary artery disease, we may take longer and take a more thorough approach to ask all the right questions about their occupation, their smoking habits, et cetera, et cetera. So you kind of have to tailor that type of assessment to your location, where your specialty, where you're working, and also to your patient condition as well. We are going to assess risk factors. We know now, after the last few slides, there are so many things that can affect cardiac dysfunction, from medications to lifestyle factors, all the things, right? So we want to assess their risk factors, their genetic history, all of those things. And we'll talk about that a little bit more on the next slide. And then lastly, we're also going to assess their anxiety. So anytime a patient is having respiratory or cardiac difficulty, you can almost guarantee they're going to have anxiety. It's a very anxious situation. And here on this slide, you can just see a sample health history for assessing someone who has some cardiovascular, what are their risk factors, assessing their risk factors, right? So what's their age? Where do you live? What's your occupation? We want to know, are you around smoke all day long? Are you working in a factory where you're dealing with harmful chemicals, things like that? Do you have any health problems? Do you take any over-the-counter medications? Do you have a mother or sister that has developed coronary artery disease or a heart attack before the age of 65? And then down to lifestyle changes. What's your current stress level? Those kinds of things. So you can review all of these questions on here. This is just going to be assessing your patient's risk factor. And again, you have to let your patient's situation kind of guide whether or not you have the time to do this. Obviously, if it's in the middle of an emergency, that would not be the right time, but maybe even after the emergency, as we're trying to teach our patient how to live with or change their lifestyle, this would be great to incorporate in there so that you can take their answers and then provide some teaching on the things that may not be ideal. And now to the nitty gritty of our physical exam for our cardiovascular assessment. So when we are doing, first things first, when we're doing our physical assessment, we're going to inspect, right? We're always looking, we're going to inspect for signs of distress. So are they having chest pain? What is the color of their skin? Are they pale? Are they pink? What's their mucous membrane color? If we look in the inside of their cheek, is it pale? Is it blue? Is it pink, right? And then we're going to look at maybe their feet and ankles. Do they have any edema? Do they look swollen? What's their overall appearance, right? So we're going to inspect. Next, we're going to palpate, okay? We're going to palpate for all the peripheral pulses. We're going to palpate for skin temperature. Remember, we talked about poor circulation is going to have cooler skin temperatures. Warmer skin temperatures is going to be better circulation, right? We're going to palpate for edema, right? A lot of times when we're assessing edema, we are pushing in on typically, I mean, you can have edema in your upper extremities as well, but typically you're seeing it in your lower extremities, calf to ankle area. And we're going to palpate that. So if we see it looks swollen, we're going to push down and see our indent there and see how long our indent lasts. Okay. We're also going to palpate for heart pulsations through the chest wall. Okay. And then, of course, we're going to palpate for areas of tenderness like we always do, right? And then lastly, we're going to auscultate. So we're going to listen. We're going to listen to heart sounds and we're going to listen to their blood pressure. We're also going to listen to their lungs. Okay, that is so important to know. Remember, the lungs and the heart work together to oxygenate the body. Problems in one can cause problems in the other. Okay, so we're going to listen to heart, lungs, and blood pressure. Okay. We're also going to assess their pain. So we're going to ask them to describe their pain. Where is it located? How long has it been going on? How often does this happen? Is it radiating anywhere? What makes it worse? What makes it better? Chest pain may also be caused by a musculoskeletal or respiratory condition as well. For example, if a patient has a fractured rib or pleurisy, right, which is inflammation of that pleural space, those injuries may cause some chest pain that are not cardiac focused, right? You can usually differentiate cardiac pain because it's usually in the center or on the left side of the chest and usually radiates to the left arm, which is actually, it's more common in men when it radiates to the left arm. And usually cardiac pain does not change with inhalation or exhalation. Okay? Women tend to have more atypical symptoms like fatigue, back pain, nausea, things like that. So sometimes it's kind of hard to differentiate with women. The pain typically lasts several minutes, and it also may go away and come back. We're also going to assess fatigue. So just remember, fatigue is a subjective experience. Determining whether a patient has fatigue has a lot to do with how they think that they normally act and feel. The patient may report that they feel tired or that they lack endurance. Fatigue is a common symptom of various oxygenation problems, including anemia and heart failure. Ask your patient to rate their fatigue on a 0 to 10 scale, just like pain, okay? And then we're also going to assess for dyspnea. Remember, dyspnea just means trouble breathing, shortness of breath, okay? We're going to look for signs of hypoxia, which can be associated with cardiovascular disease and anemia, as well as with respiratory problems, because we know that these two systems are connected, as we just mentioned, right? As with pain, just keep in mind, anytime you have a patient that has dyspnea, they're also going to have anxiety, okay? The people who cannot breathe are extremely anxious, okay? And then lastly, we're going to assess for peripheral, remember, arms, legs, feet, hands, away from the heart, peripheral, and central, so centrally located, right there in the middle in our core here. We're going to assess for peripheral and central circulation and perfusion, okay? And we'll go over those on the next slide. Signs of impaired perfusion. I cannot tell you how important this is to know. You may as well just write this down on your forehead and look at it in the mirror every single day, okay? You need to know this. I cannot stress that enough. What kind of things are we going to see with a patient that has impaired perfusion? Okay, we are going to palpate the peripheral pulses, assess for skin color, assess for temperature of the skin, and note the distribution of hair on the extremities. Okay, keep in mind, weak pulses, cold feet, lack of hair, and shiny skin on the lower legs and feet usually accompany peripheral vascular disease. Okay, these are also poor signs of circulation or signs of poor circulation in general. Okay, remember, these are also signs of poor circulation in general. This means, for example, if you have a patient with wrist restraints and you do your skin check and you are noticing that your patient has a cold and pale hand, you may suggest loosening that restraint. It's too tight. It's cutting off that circulation, right? Hypotension or low blood pressure, that can be a sign of impaired perfusion as well, right? Because the blood is not getting where it needs to go. We're going to look for skin ulcers that often accompany severe venous or arterial disease, just like we talked about a couple slides ago, stasis ulcers, right, with that venous insufficiency. So skin ulcers can be a sign of poor circulation. We're going to check for edema of the feet and the ankles. This is one symptom of heart failure that you'll see. Decreased or absent pulses, like we talked about. Super important that when you are thinking to yourself, am I feeling a decrease or an absent pulse? Go ahead and palpate the other extremity. If you're checking a pedal pulse and you're like, oh, I think this might be not a normal pulse. I think it might be decreased, or I think I can't find it. Feel the other foot and let's see if are they equal on both sides. both sides. Compare each side of the extremities when you're checking those pulses. Another sign here would be a prolonged capillary refill. If their capillary refill takes 10 seconds to come back instead of the 3 or under, like we've learned is normal, right? Decreased urinary output. Remember, if there is no blood flow to the kidneys do not produce urine. Okay? They need blood to work. So if you're seeing decreased urinary output, your kidneys are not getting perfused. A lot of times that is why you see surgery patients who are on strict INO after surgery, because we want to make sure that is there perfusion. Like if they lost a lot of blood during surgery and we notice they have no output, that may be telling us that we have low blood volume. And so we want to be aware of that. Okay. So it's not necessarily always about like, are they peeing? Is their bladder, is their ureters, is their kidneys working as far as that general system goes? But that could be a circulation issue in and of itself, okay? Shortness of breath, of course, is going to be a sign of impaired perfusion as well. And those are the main things. So again, you have got to memorize the slide, know these symptoms like the back of your hand. And these are the 5 P's of a neurovascular assessment. This is super important to know. So you've got pain, pulse, pallor, paresthesia, and paralysis. So pain, remember we talked about that. If you have decreased circulation or no circulation, you got ischemia. Ischemia causes pain, right? Pulse, we need to make sure that we have a normal pulse, because if we have a weakened or an absent pulse, we don't have perfusion, okay? Pallor, again, if you're having a pale extremity, or paleness in general, we probably have either some blood loss or some poor perfusion, right? Because that red tinting, that pink tinting of the skin comes from the color of the blood. So if there's not enough perfusion, we're going to have a pale extremity. Paresthesia, that just means numbness and tingling. So if you've ever, sat on your foot for a little while and you got up and your your foot started tingling, you're like, oh my gosh, my foot's asleep. You have had paresthesia. Right? You have cut off circulation to your foot, and that's, very painful, right? It's painful when that happens. And then paralysis. So if they absolutely cannot move that extremity, that would be another sign of poor circulation as well. This should be review for you. You should already know all of the peripheral pulse points, but this is just a refresher for everywhere that you can see where we can feel those pulses in those arteries. So we have temporal, carotid, apical, right? So right over there on that left side. Remember that also can be called the point of maximum impulse or the mitral heart rate, right? You've got your brachial, your radial there on the thumb side, femoral there in the groin, popliteal behind the knee, dorsalis pedis on the top of the foot, and then your posterior tibial, which is on the inner side of the ankle, kind of right behind that ankle bone. Remember, a lot can be said about circulation from those peripheral pulses. If you notice that you have a very strong femoral pulse and a very weak pedal pulse, we know that they have some kind of disruption in blood flow from the femoral down to the foot. So maybe they have a blood clot or something that may be cutting off that blood supply. It's an important assessment piece. This is just a reminder here, also should be review. But for assessing an apical pulse, once again, mitral pulse, apical pulse, point of maximum impulse, all the same thing and all right here. So right there at that mid-clavicular line, 5th intercostal space, you can see how the heart kind of flies out to the left side there. And that tip right there is what you're listening to, the apex of the heart, right? It is the most accurate heart rate that you can hear. Typically, you will assess with this when you're giving significant cardiac drugs such as digoxin, if you've ever heard of that, or digitalis, which is the same thing, just one's the generic name and one is the brand name. When you're giving that medication, can have a significant effect on the heart rate. So we have to listen for a full minute, and we listen only to the apical pulse. So there is certain kinds of drugs where that is a requirement. And then same with like infants. We know that we listen to the apical pulse on an infant for 1 full minute in that location rather than palpating any other type of peripheral pulse. After our physical assessment, we may move on to do some tests of blood oxygenation. So pulse oximetry, we know that this is a non-invasive way to check and see oxygen saturation, right? See how much of that hemoglobin is saturated with oxygen in the bloodstream, right? So pulse oximetry is a good indicator. Also, arterial blood gases, or ABGs, if you've ever heard of. Typically, those are drawn by somebody with training. Could be a nurse, could also be a respiratory therapist. They draw out of an artery, not a vein. So that is significant because once you puncture an artery, I mean, if you don't apply pressure to get it to stop bleeding, you could bleed out with that. So it does take some skill. But those arterial blood gases are going to show what's our pH of our blood. It's going to show, are we acidic? Are we basic? It's going to tell a lot about different types of respiratory compromise that could happen. Some other lab testing that they may order, a lipid panel is going to measure your HDL cholesterol, your LDL cholesterol, and triglycerides. That can tell us a lot about the patient's diet. It can also tell us about their risk for atherosclerosis, or that plaque that builds on the vessel walls, right? And then C-reactive protein is another lab that they may order. This is the most reliable screen for arterial inflammation. And then cardiac monitoring. So I'm sure everybody's heard of an electrocardiogram. This is a rendering of the electrical activity in the heart. So typically 3 to 5 electrodes placed on the skin of the chest, just display a waveform on a monitor screen or a printout. And it's going to illustrate electrical activity, but not mechanical activity. So in other words, the EKG or ECG is going to reflect what the nerves are telling the heart muscle to do, but not what the heart muscle is actually doing in response to that instruction. Okay. The purpose of cardiac monitoring is to identify the patient's baseline rhythm and rate, recognize significant changes in the baseline rhythm and rate, and then recognize any lethal dysrhythmias that may require immediate intervention. We are not going to get too in the weeds with cardiac monitoring. I'll go over it briefly here. You'll learn in a later class how to actually read strips, but this is just a little introduction for you. So when we're talking about cardiac monitoring, you can see down here on the bottom left, you can see what normal sinus rhythm looks like. So you can see the P, that's your P wave. You can see the QRS, that's your QRS complex. And then you can see a T wave at the very end. So kind of what we're looking at here is, so when we're talking about the P wave, this is going to represent the firing of that SA node, right? Like that pacemaker of the heart. So the P wave is showing us what the SA node is doing when it fires. And then conduction of that impulse through the atria. Okay. In a healthy heart, this leads to atrial contraction. That's what we want there. Okay. And then we move on to the QRS complex. So this is going to represent ventricular depolarization, and it leads to ventricular contraction with that QRS complex. Okay. And then once we get to the T wave, this is going to represent the return of the ventricles to an electrical resting state so that they can be stimulated again during another heartbeat, right? At this time, the atria are also going to repolarize, but they do so during the time of ventricular depolarization. So they're obscured by the QRS complex and can't be seen on that ECG complex. And then that U wave is not always seen on an ECG, but may be detected with some kind of electrolyte imbalance, such as hypokalemia, which is low potassium, or hypercalcemia, which is high calcium. And again, what are you going to do about it? So first thing, this is our nursing interventions, right? What are we going to do about it? Well, we're going to manage our patient's anxiety. So anxiety actually activates the sympathetic nervous system and triggers the stress response. So hormone changes are occurring, including the release of hormones like aldosterone, which is going to promote fluid retention and increase the blood pressure, which is not exactly what we need to do when we are having cardiac dysfunction, right? We don't want fluid retention or an increased blood pressure when we are having cardiac problems, okay? The heart rate and contraction force is going to increase under anxiety as well. And then peripheral and visceral vessels are going to constrict and the blood is going to clot more easily, which again, we don't want that, right? We are going to provide clear and factual information and keep our patient and our family informed about the treatments that are going to be given to the patient, right? Many patients are reassured by the presence of a family member. We want to include them in their care, okay? We also want to promote circulation. This includes venous and arterial circulation. So measures that promote venous return increase the flow of blood back to the vena cava to the right side of the heart. So venous return, we're talking that deoxygenated blood coming back to the heart so it can get reoxygenated, right? So things that promote venous return, okay? This includes elevating the patient's legs above the level of the heart to promote that venous return. We know that if we tilt the patient that way, the blood is going to flow because of gravity easier towards the heart, right? Also, having the patient sit in a recliner and elevate the legs. Any type of flexing of the hip, legs, and knees is going to constrict the veins and it's going to slow that venous flow. So setting them with elevated legs is going to help, okay? We're going to tell them, please avoid sitting with your legs crossed so that we don't cut off that blood supply. We're going to encourage and support early and frequent ambulation, okay? This is all the time, but this is especially important for your older adults who have poor circulation already. This is important for patients post-op. Things like that. Any contraction of the leg muscle is going to allow that venous blood to flow upwards against gravity and back to the heart a little easier. So if you think about bending your leg is going to kind of shoot a little bit of blood upwards because it helps go against gravity. It helps it go up there and propel it up towards the heart. We're going to also encourage and implement range of motion exercises. So passive range of motion, active range of motion, whatever it is, we need to get them moving, right? We're going to apply compression devices. So SCDs or sequential compression devices. If you've ever seen in a hospital, those little pumpy up things they put on your legs. A lot of patients will say, it's my leg massager, right? But what it's actually doing, it's just squeezing those legs so that we can keep that blood flowing and it won't be stagnant there, therefore causing a blood clot, okay? Same with those anti-embolism stockings or TED hose. We put those on there so that we can keep the edema down and then also increase that circulation as well. We're going to educate our patient not to smoke. We are going to educate our patient to exercise regularly. And we are going to educate our patient to have proper foot care, right? So when circulation is poor, it is especially important to take good care of the feet. Okay, we want to prevent an injury on the feet, as even the smallest sore can become quickly infected and poorly heal on patients who have poor perfusion and circulation. Because remember, the feet are the farthest away from the heart, and if we don't have good blood supply to the feet and legs, we can't get nutrients and oxygen there to help that wound heal itself, right? So we want to instruct our patient to wear good fitting shoes and socks. We don't want them to have any blisters from poor fitting shoes. Things like that. We don't want them walking around barefoot. That can cause an injury as well. And then we want to educate them too that warmth can provide vasodilation, right? So we apply heat and our blood vessels get bigger. So we want to prevent long periods of exposure to the cold. We also never want to apply heat directly to a limb like a heating pad or a hot water bottle because that will increase the risk of burns. So we always say when applying heat or cold, we want 15 minutes on, 15 minutes off, and we never want it directly on the skin. We want some kind of barrier in between like a washcloth, a pillowcase, a towel, something like that. Okay. We're also going to educate our patient to, we're going to help them prevent clot formation. Okay. So a thrombus is a stationary clot adhering to the wall of a vessel. Okay, a thrombus is a stationary, so not moving, clot that is adhered to the wall of a vessel. An embolus is a clot that travels throughout the bloodstream. So if you've ever heard about a pulmonary embolus, that was once a thrombus that has now gone on a trip into the lungs and has caused lots of problems, right? Clots can form after injury to vessels or in response to some type of hypercoagulability, whether they have thick blood or they have some kind of disorder that causes clotting, things like that. All of the strategies that we talked about to promote venous return are also going to help clot formation. So we talked about elevating the feet, not crossing the legs, using SCDs, using TED hose, those kinds of things. Early ambulation, all of those things are going to help prevent clot formation. Administering medication. So cardiovascular medications are used to enhance cardiac output, providing increased blood flow and oxygen to the organs and tissues. Okay, we talked about those. That can help. And then perform CPR. Should our patient lose a pulse, we're also going to perform CPR, right? And here is a little clicker check. So, which nursing intervention is used to reduce the risk of clot formation in the legs? Is it A, keep the patient's hips and knees flexed while the patient's in bed? B, apply cold compression intermittently while in bed? C, turn the patient frequently or encourage frequent position changes? Or D, limit hydration by limiting oral intake? The answer is C. Turn the patient frequently and encourage frequent position changes. So, this is going to prevent vessel injury from prolonged pressure in one position. Anti-embolism stockings, or SCDs, those sequential compression devices that we talked about, those are what's going to be frequently used in perioperative patients to promote that venous return and prevent that clot formation. Promoting adequate hydration to keep the blood from becoming viscous or thick, because viscous blood is going to clot more readily. Right? We don't want to keep the patient's hips and knees flexed. We talked about that. That's going to inhibit venous flow back to the heart. We don't want to apply cold compression intermittently while in bed. Warmth is what's going to dilate those vessels. Cold is going to constrict them. And then we really never want to limit hydration and limit oral intake unless you have a patient that is specifically on some kind of fluid restriction, which we didn't have enough information in the question to determine that.